ADH gets the aquaporins installed in the distal nephron, right? Once that happens, then the medullary concentration gradient can be used to concentrate the urine, right? To pull out the water. And remember, the whole point of pulling out the water is so that it goes back into the bloodstream, right? So it's held in the plasma volume instead of lost into the urine. Okay, so if ADH is doing this important thing, how is it released? What is the mechanism? Well, ADH is released from the posterior pituitary, and the posterior pituitary is kind of strange because it's a bunch of axons, essentially. The cell bodies of the axons that are in the posterior lobe are actually up in the bottom of the hypothalamus. But the axons come down and they're modified neurons. So instead of releasing a neurotransmitter across a synapse, okay, the neurons that release ADH are releasing ADH into the bloodstream instead. So instead of a synapse, you've got capillaries on the other side. So the ADH is actually produced up here in the hypothalamus and then shipped down the axon for release at the distal end of those, at the distal part of the posterior lobe. The stimulus for ADH secretion is osmolarity, specifically extracellular osmolarity, okay, which is what we would want it to detect. So when the blood's osmolarity starts to increase, in other words, a water deficit is occurring, okay, then the amount of ADH that's released increases. The mechanism of this is actually about cell shrinkage, right? When the blood becomes hyperosmolar, even a little, it tends to draw fluid out of cells. Those cells get smaller, and that is what is detected as a change in osmolarity. So a change in cell size is the proxy for a change in osmolarity, right? Cells shrink, that's detected, ADH is released from pre-made vesicles, and then ADH enters the bloodstream, right? So once our plasma ADH is increasing, not long after that, water permeability in the distal part of the nephron increases, right? Because aquaporins are placed. That increases water reabsorption, decreases water excretion. Now, decreasing excretion doesn't directly fix our water deficit, but it does keep it from getting worse, right? What is going to fix the water deficit is you got to bring water into the body. ADH is our primary, not on this page. ADH is our primary thirst hormone. So when we are thirsty, the reason we are thirsty is because our osmolarity is creeping up, right? So we drink, that adds water to the system and increases it. Now, another separate system that also stimulates this are the arterial baroreceptors. Okay, we talked about those last week. When blood pressure starts to fall, when blood pressure is decreased from what the body wants it to be, we get sympathetic nervous system stimulation, but we also get stimulation of ADH. Why? Because if our blood pressure is low, chances are our plasma volume is low, right? So if your blood pressure is low for whatever reason, you're going to tend to hold on to water. Your ADH is going to tend to be high, okay? This plays a role in a number of cardiovascular diseases. The low blood pressure leading to elevated ADH, and sometimes it can become problematic. All right, so a number of things can increase and decrease ADH. Plasma osmolarity is sort of the standard, the what the system is for, okay? But there are other things that affect it too. Blood volume all by itself. So when your blood volume is decreased, your ADH goes up. When your blood volume is increased, ADH goes down. Same with blood pressure, like we were just talking about. Then we get some other odder ones. Anything that causes nausea tends to increase ADH, right? So like patients who are undergoing chemotherapy, right? They can end up holding on to fluid incorrectly, right? Because the nausea is triggering the release of ADH instead of the osmolarity. Morphine, nicotine, cyclophosphamide all can increase ADH, as can hypoxia. On the other side, decreasing ADH, alcohol. This effect is actually very prevalent, right? Small amounts of alcohol tend to decrease antidiuretic hormone. In other words, they increase urine production, right? You know the classic game where you lock the bathrooms and you get everybody free drinks, right? ADH is your problem here. Because you take a little ADH, or you take a little alcohol, and then suddenly everybody in the room is making more urine, right? So it's a great way to earn your money by paying to unlock the bathroom. Clonidine is an antihypertensive, which we don't really use for hypertension anymore, but we do use it for some psychiatric and behavioral conditions, clonidine. But it has a tendency to decrease ADH. In other words, increase urine output. And then haloperidol is another one. Haloperidol is a medication that we frequently use in psychotic patients and in patients who are being a problem for the healthcare team. Okay, this is one of our chemical sedations, chemical restraint. Yes?
I can't remember if you touched on this or not yet, but in diabetes, is that also...
You're talking about the increased urine output in diabetes? Has nothing to do with ADH.
Oh, okay.
Instead, it's osmolar.
Okay.
The reason that diabetics have high urine output is they have a lot of sugar in their urine. So they have an osmolar load that's pulling water towards it all the time. All right, so some characteristics of ADH. I actually think, like, in terms of understanding cardiovascular and fluid balance, ADH can be a really good helper, right? Like I would encourage you, get a grasp of what ADH does and how it affects the body, and it will make you a better provider in terms of the cardiovascular stuff, because ADH is sort of in the center of fluid balance because it deals with water and osmolarity, which a lot of other things affect, right? So it's a pivotal thing. Clearly, evolutionarily, that must be the case because this is our only hormone that is released directly from neurons, right? So this is a big one, ADH. A little talk on plasma osmolarity. Generally, and I'm not going to ask you to calculate this on a test. Okay, I promise. Okay, this is just more showing you where's plasma osmolarity coming from. Okay, mostly it's sodium, glucose, and urea. Those are the primary solutes. We call it the crystalline colloid, right? These are the solutes that are creating most osmolarity. Okay, so you can estimate plasma osmolarity from blood lab values, right? So you take 2 times the sodium concentration, you add the glucose concentration and the urea concentration, and that gives you an estimate of osmolarity, right?